Good morning, everybody. It's a pleasure to be here. So when I graduated my undergrad, I knew a lot about statistics and math and very little about what determined health in populations, but I knew I wanted to put these things together. My first experience as a grad student, that's me, very excited to test out all my analytic skills, was working in the area of colon cancer, and colon cancer screening more specifically. So colon cancer screening is really important because not only does early detection lead to improved survival, but it can actually be preventative by detecting precancerous polyps. And my job was to figure out who is getting screened in the population. And my thought, naively going in, not knowing a lot actually about colon cancer, was that we need to focus on individuals who have family history, maybe some genetic predisposition. And in fact, that's what bore out in the data. That's who was getting screened. The people that weren't getting screened were people without these. And then I learned from the oncologists and the cancer epidemiologists I was working with that actually 70% of colon cancer cases are what we call sporadic, which means they occur in people without family history, without genetic predisposition. And that number bothered me I think about that number almost every day, because I started to think, what happens when we focus our analytic tools and efforts on actually a minority of where the cases actually occur? So I work in public health. I research populations. I look at how diseases and health outcomes transmit in populations. And sometimes these patterns are only apparent when you stand back and study millions of people at a time. So how do we improve health of populations? And I'm going to talk about this in the context of power and prediction. So we can improve health by focusing on individuals and making sure that their individual outcomes are optimized. And machine intelligence has a large role to play here. This is where you see a lot of the activity. And if that happens one at a time, hopefully equally and systematically in the population, eventually it's going to lead to population health impacts. From my vantage point, I start with populations first. And instead of focusing on individuals, I focus on structural factors that cut across individuals, with the idea that if you work on those structural factors, you're likely to have a bigger population health impact, and hopefully won't reduce health inequities. And specifically, we build predictive models to help us make better decisions in this space. And in the past 15 years that we've been doing this, we've seen some really interesting impacts when you predict in populations versus individuals, which I think is relevant to our prediction power discussion today. And I'm going to frame it specifically in the context of precision public health, which is actually a controversial term in my setting. So we heard of precision medicine, right treatment for the right person at the right time, and machine intelligence is playing a large role there. Precision population or precision public health is a term that's been thrown around also the last few years, but is not widely accepted by those in the public health community. So this debate was alive last year. There were two big editorials, one in the New England Journal of Medicine, one in the Lancet. On the one hand saying there is no need to add the word precision to public health. And in fact, by doing so, we're actually detracting away from our goal in public health, and it's making us focus more specifically on individuals and taking us away from population health impacts. It can actually do more harm than good. On the other hand, in the Lancet, there was the suggestion that there's never been a better opportunity with precision public health to reinvigorate the discipline, to make sure that we're being more strategic about how we use our resources and power to make better decisions about how we achieve population health impacts. And my perspective, of course, is somewhere in the middle, but I do think it depends on how we use it. So here's a vintage slide, and I put it up here because we've known for a very long time that the factors that influence health outcomes are certainly at the individual level, but actually happen at the societal, community, and socioeconomic level. Actually, most factors that determine health outcomes in populations, the data that I look at almost every day, are social and economic. Except these aren't the factors that are necessarily making their way into our machine learning algorithms. But I think with advances in machine intelligence and the ability to work with data that honestly about 5 years ago, 10 years ago, we couldn't even dream of working with, it could actually offer a huge benefit in this space. So unstructured data, data from our environment. This nice figure by Prosperi and al. Talking about precision population health is talking about the different layers of data. And the more we move to relationships, community, and society and harness this data into our predictions, the better we will be at having population impact in the ways that we hope that we are in a precision public health approach. One example from others in this space. So again, I study chronic disease outcomes. We look a lot at the built environment, one of the big structural factors that affects health outcomes like type 2 diabetes. And up to recently or historically, we have pretty crude ways of measuring the environment, things like walkability, green space. Now with advances in machine learning, visual analytics, convolutional neural networks, we can actually look at pictures of our environment and understand how that's shaping society and health outcomes in a much more sophisticated way. One of the areas that I've worked in specifically is about transit infrastructure and understanding the health impacts of investments in transit, which is a really thorny issue. But we've done this both in the GTHA and in Ottawa, showing that short trips, small substitutions with public transit, or walking 15 minutes or more a day actually can have population health impacts in terms of the prevention of type 2 diabetes. So hopefully I'm giving you a little bit of a sense, for those of you that are more familiar with medical and clinical applications, of what a precision public health approach could look like. We're talking about identifying risk on lots of dimensions, and with the advances in machine intelligence, we're doing that in a much better way, much more comprehensive way. We're assessing distribution of risk, who does it affect and to what extent, and then with that information, we're matching resources in a smarter and more efficient way, potentially. And that's the power. So the resources I'm talking about mostly in the public health setting are the decisions, for example, that governments make with tackling strategies. So $800 million for a diabetes strategy, dementia strategy, COPD strategy, et cetera. We have millions and billions in dollars of investments in this every year. And are we using the best intelligence to make those decisions? But those resources are power, because once we identify who could benefit, they get the resources. And there can be some unintended consequences to that. And it really underlies the difference between predicting risk in individuals versus predicting risk in populations. So we developed a diabetes model that predicts diabetes risk in populations, 10-year risk, for the purpose that this model can be used to inform how you roll out a prevention strategy. You've been given billions of dollars to say, solve this diabetes epidemic that's increasing every year, and use these algorithms to do it in a smarter way. And this is just focusing on one of the most well-known risk factors for type 2 diabetes, which is obesity. Algorithms well-validated, works in multiple provinces, 2-3 years of technical development to make sure it works. It works. And you can see it predicts risk, and as we get to those that have higher levels of obesity, their risk is higher. So you look at that prediction algorithm and you say, okay, what is that telling me to do? When I say the right interventions for the right populations, I'm saying I need to focus my interventions on those that are most likely to develop diabetes in the next 10 years. And in fact, that's what we do. So when we had an $800 million diabetes strategy, and the Auditor General called out the province to say, after those investments, what happened? Why did diabetes rates actually go up? Well, the answer could be not a problem with the model, not that the model was used for those investments, but how models like this or intelligence can be used. So when you actually look how many diabetes cases develop in the population, most of them develop in a category what we call overweight. So there are risks of carrying some excess weight. The risks are not zero in this population. And there's so many more people in this population that essentially we're not even looking at when we're thinking about targeted interventions for diabetes prevention. The strategies that were in the investments I was talking about earlier were targeted at the highest risk among the highest risk of the population. So we're failing to have the impact that we're actually intending to with our investments. This is another example, a model to predict the highest cost users of the health system, sometimes known as high resource users. So 5% of the population uses over half of the healthcare resources, known as high resource users. So we developed a model to predict who these high resources users will be in the next 5 years, with the idea if you know who they are, you can, again, target your interventions and activity appropriately. And what you start seeing is risk increases with the more chronic conditions you have. Makes sense. Someone that has 8 chronic conditions has a very high probability of becoming a high-cost user of the healthcare system. But as we start getting more precise and focusing in on these subpopulations, we're actually missing the vast majority of the population. And in fact, changing their risk takes way more money and costs because they're already so far gone down a trajectory. Turning that back is very difficult, comparing to someone that maybe just has 1 or a high-risk behavior. So this idea isn't entirely new. In the late 80s, Sir Geoffrey Rose, a famous epidemiologist, wrote about this in his seminal paper, Sick Individuals, Sick Populations. And he coined it the prevention paradox. The idea that more lives can be saved by shifting distribution instead of focusing on high-risk approaches, which precision approaches almost always lead to, if you look at how they're rolled out. And you can actually have unintended consequences like widening inequities. So let's talk about that for a moment. So I also spend a lot of time studying death, and specifically premature death. So premature death is a death, in this case, before the age of 75. And the reason why that indicator is important is because many of these deaths are preventable. And if you think, well, how can they all be preventable? Well, some of them can be prevented by better care, treatment, medical care. Certainly, that's a good part of it. A lot of them can be prevented by preventing chronic diseases, which actually make up the majority of premature deaths in this country, this province. So this is every single death that's ever occurred in this province that you're in today. So, and this is a graph that actually looks very similar to many countries around the world. These are the premature mortality rates according to socioeconomic status. So those that are the least deprived have the lowest rates, that's the bottom bar, and those that are the most deprived have the highest rates. Now, premature mortality is falling for everyone because overall we are making improvements in health, especially in our healthcare system. But the inequities are slightly widening, and you can sort of see it in the graph, and there's a relative index of inequality there to show numerically that those numbers are actually increasing. And this is one of the consequences when subgroups of the populations are benefiting more than others. And perhaps it's because there's a shift of resources and power to those specific subgroups. Let's look at another situation. So imagine a situation where there's a difference to begin with. We're not going to erase that health inequity in premature mortality. It's very difficult. That's a whole other debate. But are we making it worse? And actually, we now have evidence from Europe, US, and Canada that, in fact, it is getting worse. Life expectancy is actually falling in countries, certain countries around the world, certain segments of the population. It's very hard in the context of rising life expectancy for the last 100 years to start seeing falls. So imagine in the beginning of time, here in 1992, differences but not widening, and then all of a sudden, those that are least deprived just pull away at a much more dramatic rate than the rest. And you see a 60% difference in the latter time period as opposed to the beginning. This is some of the impacts that can happen when you're looking at precision in the context of subgroups of the population. You start getting inequities. And these inequities, we know, we pay the health and economic consequences to the healthcare system. So reduced life expectancy, reduced population health, also cost the healthcare system more. This is Toronto, by the way. This is not made-up data. This is the picture of premature mortality in this city. So maybe it's not the models themselves that are the problem. And we can work harder to make our predictions better. And as I said earlier, we definitely have to think about the data that we're feeding in to these algorithms to make sure we're being more comprehensive about understanding risk. But it's probably more likely the implementation of the models that we need to think about a little bit more. So I spent a lot of time talking to decision makers. Actually, when I graduated my PhD, I did 40 key informant interviews with decision makers to understand how they used evidence, because I was so frustrated about how evidence was and was not being used. And I learned a lot from that. It really shaped my thinking. And the one thing I realized is that as academics or as researchers, we're often creating evidence that isn't exactly matching the way that they intend to use the evidence. And that has to be the first task in understanding when we create models. If we're going to get more precise about subgroups of the population, is that actually what they intended when these models are being developed? So that's a lot of conversations up front and thinking through execution. The second thing I've realized is that I think there is, and this might be an unpopular opinion, but a misplaced focus on interpretability. So we're developing these more sophisticated models, and the first thing we say is we have to make sure they're interpretable. We have to make sure people can actually use them and understand what's in them. And I see a lot of risk to that. So first of all, even simple models are hard to interpret because most people don't understand really the mechanics and the math of, just because you can see the variables in the equation doesn't mean you actually understand the mechanics of what's happening. But second, it's probably just confirming the cognitive biases that people have. So they feel better because it looks familiar to them, but that's going to be really hard to result in innovation. I think we need to spend more time focusing on performance, how the model's performing, certainly, which we do reasonably well to some extent, and the impact metrics. What are we actually intending to do with machine intelligence? What's the end goal of that particular algorithm? And we developed a framework to think through how to implement models in practice. And one of the key things was asking that question, how does it perform? You need to build that trust. Once the performance metrics are there, the trusts are there, and it will be used. And what impact is it having on decisions? What decisions are people making as a result of these algorithms? And it might actually be the opposite of the intended goal of the algorithm. So I hope I've given you something to think about in the context of prediction and power and population health. So I'll end just on these 3 questions to keep in your mind as you enjoy the rest of the day. So first, definitely there's a role for using precision and machine intelligence in improving population health. I truly believe that. But what data are we feeding in? And is it actually capturing the differences that we see across populations? Second, who does it apply to? If it only applies to the 30%, do we actually understand what that means for the 70%? Do we understand what that means for population health and health systems? And lastly, how will it be used? We should always start and end with this question, because even the best performing, most powerful prediction model, if used inappropriately, can shift power and resources in ways that we do not intend, and actually can undermine our goal for having a healthier society. Thank you.